Welcome to ACAP Guilford's monthly meeting. We're so glad to have you join us. Do you know about ACAP? Let me give you a little introduction before we move on. ACAPcommunity is an educational 501c3 nonprofit organization that offers information, resources, support, and community for those of us who are caring for our aging parents. As you can tell from our name, our focus is on supporting adult children as they care for their aging parents, but everybody who's a care provider is welcome, whether you're caring for a friend, another family member, or you're a professional in the field. Each of our 9 ACAP chapters is located across the Eastern Seaboard, and we all offer monthly programs that address issues related to aging, family dynamics, and adult-child care providing. Presenters are experts on the topics they address, and many of them are also caring for their aging parents or in-laws. ACAP Guilford meets on the third Thursday of every month. Our meetings begin with a light lunch and a chance to speak with others who are caring for their parents. We begin at 11:30, and a little hint is please RSVP if you would like to be here and have lunch with us. Our meetings take place at Senior Resources of Guilford at 1401 Benjamin Parkway in Greensboro. Folks who cannot attend in person can watch the recording of this presentation on ACAPcommunity website. Oh, and I didn't tell you, the actual program begins at noon. So come for lunch at 11:30 and stay for the program at noon. We would like to thank our sponsor for today, Carolina Pines. Heather Young, would you come up and tell us a little bit?
Hello, everybody. Hi. I am Heather Young. I am the Senior Living Consultant for Carolina Pines Retirement Community. We're a brand new, independent living, all-inclusive retirement community under construction, opening in November of this year. I don't know if any of you are familiar with the old Pilot Life building in Greensboro.
Yes.
We're being built right next to it. So I have some brochures here with my card, and inside of those are also flyers for our next round of information seminars. We do hold those monthly, and our last round will be October 16th and 17th at the Sedgefield Country Club. So if you'd like to come, just take a look at the flyer. You can call me or email me at my card, and I'd be happy to talk to you further about Carolina Pines. But thank you very much for having us today. Thank you.
Thank you. Thank you to Carolina Pines for your ongoing support of ACAP Guilford. Now let's turn to our program. We'd like to hear from you. You have questions, raise your hands, and I think that the speaker will leave some time at the end for questions and answers as well. Our program today is Vision Changes in Older Adults, Causes and Treatments. Look, we often take vision and vision changes for granted, right? We may remember our first pair of reading glasses or dealing with cataracts. But healthy vision is much more, as you're going to hear. It's not only those things, but it's being able to read, being able to drive, being able to take care of you, being able to socialize, right? There's so much to it. Today, we're fortunate to have Dr. Jason Gould speak to us on this topic. Dr. Gould grew up in Greensboro, North Carolina, right here. He graduated from undergraduate school at UNC Chapel Hill with a major in psychology and pre-med. Then he attended and graduated from Southern College of Optometry in 2004 and immediately joined his father's practice in Greensboro that very same year. They practiced together in their own location until 2020, and then they merged with a very large ophthalmology group called Greensboro Ophthalmology, where he is now practicing full-time. Please welcome Dr. Gould.
Hi, everybody. You guys had a great lunch. I am Dr. Jason Gould, and I'm happy to be here to talk about some of the, I would say, the most common subjects that are, I would say, the most important to people, actually regardless of age, but especially in the aging population. There's loads more specifics that we encounter on a daily basis than this. But for the most part, these are sometimes the problems that people come in with, and I would say what people have the most questions regarding, and oftentimes the most confusion. So a lot of these are big words, they're common words, and so there's sometimes some misconceptions about what they are and about what's normal and what's abnormal. So we're going to really hit on several topics that are just all normal. And then after that, I'm going to come back and kind of go over the more common, but not necessarily normal issues that people have over time. Okay. And so I will kind of go through this. It's not to speed through it. It's just not to be overly technical, because if I do that, then I'm going to have to keep going. And so I don't think that becomes as productive for people listening to this. Okay. So first thing is, what are normal changes? Normal changes are not necessarily things that are not going to produce symptoms. They do produce symptoms. And a lot of the troubles that people have is not understanding what they should be worried about in terms of just making an observation versus experiencing a problem as a result of their observation and wanting to know, is this normal? Or what do I need to do about it? So the first thing that everybody, and all these are going to happen. So I've written down 5 things. First one is presbyopia, okay? And presbyopia is a normal condition of the eye where you lose the ability to see up close, okay? And literally what it is there's a lens that sits behind the pupil, both eyes, behind in everybody's eye, and it becomes more densely jam-packed full of cells, and the muscles that control the movement of that lens to expand or to relax and contract lose the ability to effectively bend that lens. And this starts to become a problem generally in people's mid to late 40s in terms of consistently recognizing deficits in their eyesight when they're trying to see up close. This happens to every single person. Even the people where you see them take off their glasses and look up close and they're okay, they're doing that because when their glasses are on, they can't do it. And that's the same situation as somebody who doesn't wear glasses because they don't need them. And when they look at something up close, they're having to pull it further away. And it's all normal. And like I said, early mid 40s, there's a lot of difficulties at book distances, and then from there on out, even your computer screen distances, which a lot of people are on computers. And so the treatments are glasses and or sometimes contact lenses, but prescription for people who are, let's say, have significant farsightedness, nearsightedness, or astigmatism. For people who don't have much of that or any of it, it can be managed with over-the-counter readers. The point being, we need to have to start to put on a pair of glasses in most cases to be able to see things up close. Glasses are not medical devices, so they don't speed up that process of losing that focusing ability over time. They don't slow it down. They do nothing. If you never put on a pair of glasses to see up close for the first 3 or 4 years of your struggles, and you all of a sudden start doing it, you're no worse off or better off than anybody else who are starting it as soon as possible. Okay. Multifocal lenses, that's basically taking reading power and combining it with your distance glasses, whether you have power that's significant for distance or not. It may just be a convenience of not having to take the glasses off and on in every situation. And this is what I would say the most relevant point is, especially in the aging and especially elderly population, when it comes down to correcting this problem, is it gets increasingly difficult to use bifocals effectively as we age. It is not necessarily for the reasons that we might first think of. Okay, a lot of it's a sum of the parts. Using the bifocals, whether you have a line or a no line, requires you knowing where to look to have your reading power. So if you, let's say, are at the point where you don't move around as easily, or you have spinal column issues, or you have stiff neck, or you have general postural issues, it is harder to maintain the direct line of sight looking through the sweet spot of those glasses in certain situations. This is not across the board a terrible problem for everybody. It's just a more common problem that gets overlooked. And we're our own worst enemies with that too. And what I mean by that is that we get very hung up on making sure somebody's bifocals or quote unquote all-in-ones, do-it-all lens will always work. And sometimes they can't, which means that if you get in a situation, and like I said, I'll average 3 or 4 of these sometimes a day, where I have these glasses, I just can't read really well with them. Well, a lot of times what ends up happening is we start to describe what's called a single vision prescription option, where we take their glasses and we say no bifocal, you have your distance power in there. That way you don't have to worry about looking up, down, left, right. It's all the same power. Same thing for reading. Whether you're looking straight, up, down, left, right, it's all set for reading. Okay, so versatility versus comfort starts to matter differently to people in the aging population. And I'll be honest with you, even in the middle-aged population, if you spend hours upon hours looking at a computer screen and you're having to maintain that exact viewing distance, which means if you're using a bifocal, you have to look down or you have to tilt your head back. That's a problem. So people even younger, deal with that. But it's oftentimes overlooked in the aging population, because I will have patients come in like, I just can't see out of these. And yet their corrective vision at distance is great. Their vision up close is great. And you can just say, hey, I don't know what you're talking about. Your vision tests well. This should work. Well, sometimes it doesn't. And so, and again, and I've been doing this 20 years, I would say even more in the last 5 to 10 years, I've started to really talk more about this as a specific solution, because it just, for whatever reason, kind of just sometimes gets overlooked, because we're so used to that initial conversation with your mid to late 40s individual or professional about not wanting to go off and on. And that's totally understandable, but that becomes less relevant over time for people, where we have to then maximize comfort. So that's a big one when it comes to just what we wrote down in terms of presbyopia, and that's just the normal loss of the ability to see up close. Okay. Now, next is cataracts. This is a direct tie into this, because cataracts are caused by the same process that pretty much decreases our ability to see up close. That lens in the eye that we can elongate and contract based on just holding something in front of us is now even so dense to the point where it starts to trap water and insoluble proteins, and the lens loses its clarity. Okay, it goes from looking like you're looking through, just imagine a spherical crystal ball that you could see through, and now imagine that ball starts to look a little opaque, a little yellow. That is a normal aging process, and it's called cataract, but it's due to the same process that initially allows it to not be bendable, which is where our need for glasses up close comes from. And eventually it starts to filter light differently. And so again, normal, everybody gets cataracts. Not everybody gets a specific level of cataracts by a specific age, because we're all different. We're not robots. We age differently. We all age, but we age differently. And the same thing with the inside of the eyes. And so, just for a little detail, again, organic process of the lens aging that causes presbyopia. The lens produces more cells, they trap water, insoluble proteins, they become opacified, and they become tinted. So what I've written next is pre-surgical management. All right, basically what that means is, what are people experiencing as a problem as a result of cataracts that's just not all about, I can't be corrected to 20/20 or 20/50 vision. Well, it also changes your eye power. So people's nearsightedness or farsightedness or astigmatism starts to change, okay, as that lens is getting more and more dense. Light passes through it the same way it would pass differently through your glasses as it would compared to yours, because you don't probably have the same prescription. Well, the lens in people's eyes start to do that. So you can have rapidly or sometimes slowly changing prescriptions. And so, again, part of the management, changing your glasses prescription. And then again, really the only roadblock in terms of dealing with that is, how much vision can we bring back with just a prescription change versus taking the cataract out? You can have a mild or moderate cataract, not even a severe one, and it can cause as much disruption in your vision between eye exams as it does just having a bad one. Because it's like wearing somebody else's prescription for 6 months. It's just like your numbers are off. And so sometimes cataract surgery may be done or recommended earlier than you might anticipate, we may have somebody, let's say, come in with 20/30, 20/40 vision. They can, or 20/50, and the glasses change may bring them back to 20/25 minus. But that prescription change may last 3 months, or it may last a year. We don't know. You know, we may see it back at a year later, or somebody may come in earlier because it's changed after they change their glasses. So we do factor that in, and that should be something that you can also, if you're not getting that information from your surgeon, it's good to engage in that, because there is a cost to getting glasses, and it's not a little cost in some cases. Okay, so but yeah, treatment is cataract surgery. Cataract surgery has been around for decades, longer than that. It is an outpatient surgery. It is covered by insurance. That's about as, you know, to keep it simple, as it's covered. Okay, we're not always aware of everybody's insurance situation, so somebody may have a deductible where you have to pay up to that deductible, but it's still the insurance negotiated rate. Again, this is just as important as knowing what cataracts do to you, because this is the next question. It's like, what is it going to cost? Is it covered by insurance? Yes, it's covered by insurance. Now, what it ends up costing is either nothing, which means you maybe just pay a copay, or it's the cost of the insurance reimbursement. That English translation, what does the doctor get paid by insurance for that surgery? It's approximately $700 to $800. Okay, so in most cases you're not paying that, but if you have a deductible where you have to pay up to that, then that would be the maximum amount. Cash price is $2,500 plus. Again, full transparency. This is what people do like every day. This is something that they have to encounter. So when they ask, is this covered by insurance? The answer is yes. That doesn't necessarily address all the specifics to any one person's insurance situation. Okay. And then the implant options are, they're always usually going to try to zero out your prescription. So if you're nearsighted or farsighted or having astigmatism, they make calculations of the eye, how long it is, how steep the front of the eye is, and so that way they know what implant power to order, because they take the cataract out of the eye, put an implant in, and now your correctable vision is as good as the back of the eye allows it to be, which in most cases is much better than without the cataract. So the implants that insurance covers are the ones that deal with farsightedness, nearsightedness, not astigmatism, not presbyopia. Okay. If someone has a big astigmatism, your doctor may say, I recommend this if you don't want to have a ton of leftover astigmatism, but it is not required that you do that, because the goal is best corrected vision, which means once that thing's in there, if you have glasses that you still need afterward, well, you're going to see very well with them on. They're trying to make you see well without them if they can, but sometimes certain limitations would be astigmatism. So astigmatism implants not covered by insurance. I don't know why, but it just isn't. There are bifocal implants. They are definitely not covered by insurance, okay? But they are also very hit or miss. They're similar to bifocal contacts. Generally speaking, if you have questions about that, what you want to hear is that unless you have, from your surgeon, unless you have a good, a positive history of wearing multifocal contacts, then if you don't want to have a multifocal implant. A lot of this is also my opinion, but I think it's also rooted in practical experience, knowing what people, deal with when they try to wear, let's say, bifocal contacts. It's hit or miss. There's numbers that are not that impressive that say this is how successful these things are. And now you're talking about a surgery where you then put an implant in there. So be careful about that, but they're aware of that too. It's just people will come in with these questions. It's very relevant because, again, you are going to have cataracts, and just about everybody's going to have that surgery. Okay, so those are the main issues that we generally will encounter with cataracts. You don't get points for having them removed sooner than later, and you don't have, a worsening case of eye disease if you wait to the last minute. There are some extremes that are exceptions to that, but it's in there. It's not a disease, but they do cause problems, okay? The next one that, again, you will encounter will be floaters, okay? That can look like little bugs or lint, moving across your visual field. They are a totally benign occurrence, and it is very normal. And if you look on your sheet there, you'll see a cross section of the eye. And what it shows is basically, this is like if you took someone's eye and sliced it in half down the middle, okay? In the bulk of the eye there, that's a non-solid space, is called vitreous, okay? And I wrote that it's a spherical mass of collagen, acids, and water, okay? Over time, the acids will liquefy. This is even within the first decade of your life. They'll liquefy, and you'll get little liquid acid bubbles, and they'll look like little dots kind of floating around every once in a while. I know you've had these. Well, eventually, you're going to have it happen as a much larger floater, and that's what we call the posterior vitreous detachment. And again, if you look on that little diagram there, it'll show vitreous detachment. That's where, right where in the vitreous touches the retina, that's the inner lining of the eye. When you have enough of those acid accumulations right where they touch, it's just, it means that whole thing peels away from the back of the eye. It's just like a jello mold in a bowl, where right where they touch, it becomes a liquid interface. And what happens is you'll get a big floater from the fact that right in the dead center or next to the dead center of the retina, it has the stickiest point of attachment to the vitreous. So that's the last thing that breaks loose. And when it breaks loose, it slingshots forward, slightly forward even into the vitreous itself. And that's the big floater that you see flapping around. And it'll be like something that you're trying to shoo out of your vision, and yet it doesn't work because it can't. It's inside, it's inside your eyes. So this does happen to everybody, but it doesn't always come with a complication, but it can. So the normal symptoms would be you can get an occasional flash of light. That's perfectly acceptable, okay? You'll see the floater. If this improves and it goes according to plan, you will notice the flashing start to decrease in frequency, and the floater will start to decrease in the frequency in which it gets in your way, okay? Gravity collapses the structure, and stabilizes the vitreous. It doesn't jiggle around as much, and we neuroadapt, which means our brain takes what the left eye's putting out in front of us and the right eye, and it's overlapping the two. So if one of them's got a little disruption in that field, well, it's being covered by one that doesn't. Now, this will happen in the other eye. So eventually, but they're never going to be in the exact same spot and perfectly follow each other between both visual fields. So long story short, you get used to it. It never goes away, but you get used to it, and it gets a lot less, okay? Becomes a lot less noticeable, but when you do notice it, it's under more predictable circumstances. Bright blue sky, no clouds, no trees outside, you can really notice it. You're walking out on the beach for the first time when you're on your trip and you've got nothing around you, you really notice it. If you're sitting in a room, blank walls, light colors, and just nothing on there, you can really notice it. All these things share something in common, which is you have no place for your depth of focus to land on. So the brain tends to take anything that light passes through as a target that it can recognize. And that's why you'll see floaters sometimes under more shared circumstances as it gets better, and not as often, let's say, just at any point in time, okay? Now, first of all, we all get this, and just about everybody will make an appointment to get checked out because they're like, what's going on? It's very scary. The reason for that is because those symptoms share a ton in common with retinal tear and detachment, which are very serious conditions. So when you have this happen, you do want to get it checked out. And part of our examination is to check to make sure there are no complications with the retina. If there is, you'll have a prompt referral to a retina specialist that would begin treatment for that, okay? So normal, common, it's startling, and it absolutely should be addressed, okay? All right, the next one, and by the way, there's gonna be time for you guys to ask questions, because I know it's just not always this simple. Dry eye syndrome, dry eye disease. They're very similar, but they're not all identical. Dry eye syndrome can exist at the mildest level, where it can be an annoyance. And dry eye disease means we can literally name the cause of this person's symptoms. Over time, everybody develops an increase in oxidation levels, inflammation levels, and weaker vascular circulation. The inflammation levels being higher greatly contribute to dryness. So dryness is normal, okay? That does not mean that your symptoms are just to be written off, okay? So it's just like we expect people to be experiencing it. It may not always be registering, which is great, because, look, when you show up to any doctor's exam, when they're asking you how you're doing, we're not necessarily telling them everything that's bothering us. We're spewing out every observation we can make. Now, not everybody does that, but a lot of times we're trying to sift through what somebody's just saying this is happening, but it may not be bothering them. They could just genuinely be curious. I would say that's a very common occurrence in an eye exam with folks in the aging population. It is because of this, it is very easy for this problem to reinvent itself over time. And you can sometimes never get to that point where someone's taken a direct line of treatment with you and explain to you what causes it, how do these treatments work to kind of curb the problem, and you still can expect to have to fight that battle every once in a while over time. That has to be told to patients, because if not, it's going to increase their level of frustration. And that's one thing that exists in sometimes copious amounts the older we get. It is easier to get frustrated because you've had that many more years, that many more exams to have problems on that same spectrum, and sometimes not have all the information that you need, or sometimes even engage in any of the management strategies, okay? So it's a problem rooted in a normal phenomenon with variable degrees of symptoms, and those symptoms, in most cases, burning, stinging, sandy, gritty sensation, watering, okay? Watering is the biggest confusing symptom for patients. It just doesn't seem to make sense that it would water. It's actually quite simple why that happens. When your eye is drier, the interface between the front of your eyeball and the underside of your eyelid is much rougher, okay? And because of that, every time you blink, or every time you get a gust of wind, or even a small puff of air molecules hitting the front of your eyes, you're going to feel that more, okay? Your tear film is also going to have many more allergens and dust particles sticking to the surface. So when you blink, it feels like something's in there. Again, not everybody's saying it feels like something's in there, but the eye thinks there's something in there. So it's no different than having somebody flick a wad of sand in your face. The reflex there is to flush the sand out, so your eyes water, okay? When you have a dry eye, it, in many cases, not every case, can produce the same signal. Okay, it feels like something's in the eye, but it's because it's dry. Well, it's going to pump out the watery layer. That watery layer is not designed to stay on the front of the eye. So if the eye is dry, now the problem persists. Now you can answer your own question. Why would my eye be watering if it's dry? That would be the exact reason why. Okay, a normal tear film contains oil, mucus, and the watery layer. The watery layer is produced when we laugh, when we cry, or we get something in our eyes, or when the eye is dry. So what does inflammation and aging have to do with this? Well, as we produce more inflammation in the body, those inflammatory cells inhibit or greatly reduce our ability to produce mucin, or that's the mucus derivative or mucus building block on the front of the eye, and oil from our oil glands. Without those two structures supporting the watery layer will not be held on the front of the eye. It'll roll off our cheek, or it'll evaporate prematurely with the areas that are still staying on the front, okay? And so that's where we get to talking about management strategies. So baseline treatment for everybody. Supportive therapy means non-prescription. Take a hot washcloth or hot compress, however you want to do it. Put it over your eyelids and close them for several minutes, reheat it along the way. What that does is it helps thin out the oil in the oil gland that is getting a little drier because of the inflammation. It also helps to dilate the pores of the lid margin to release the oil a little more effectively. Okay, that's why hot compresses for dryness is helpful. Lubricant tears are great because you can do that right after your hot compress. That's helpful, or you can do it on an as-needed basis, okay? An artificial tear or lubricant tear can be everything that you need, or it can be absolutely nothing if it's bad enough problem. So we'll be very, sometimes matter of fact about what you could expect from it. Sometimes that's all that you need. Sometimes it's going to be like 10% of what's going to help you, okay? Prescription therapy is, in general, narrow spectrum anti-inflammatory eye drops, okay? If we're suppressing inflammation, then we're kind of giving our eyes a reason to not have as much of a weakness in producing our tear film barriers. That's the oil and the mucus, okay? Those would be for the long term. Narrow spectrum anti-inflammatories. Broad spectrum anti-inflammatories like your steroid eye drops are going to be used for short term, okay? Every doctor is different with how they deal with dryness on the short term and to a certain degree, even on the long term, okay? And in every single case, it should be approached as if this is going to be a project, because in just about every case, it will be. Okay, so that's, again, that addresses the frustration component. Up front, it is up to the doctors and also the patients if they're hearing the information to know this is something that could carry forward a number of years, okay? And it's very easy to ignore because it may not have the fancy name like glaucoma, macular degeneration, or even cataracts, okay? All right, another less common cause, but noteworthy in some cases, is just pharmacological side effects. That would be prescription medications or non-prescription over-the-counter medications, big ones being antihistamines. So what you take for your allergies can actually make you a little dry, okay? That doesn't equal a contraindication, which means no doctor is telling you don't take this. But for example, if you're taking, let's say, Claritin because your eyes are a little runny, and you have problems with dryness, probably not the best thing to do. But again, that should be fleshed out in a discussion, with your eye doctor. There are going to be certain medications, heart medications, blood pressure medications, some real serious business that might cause dryness, and that's something that you kind of live with, but then we deal with in terms of saying, hey, we've got all these other reasons for there to be dryness. We're not ignoring the pharmacological side effects. So all different types of treatments kind of address what we can in terms of dealing with that. Just as an aside, when you read side effects of medications that involve the eyes, the vast majority of them are not causing problems for your eyes. There are a few noteworthy ones that do, but they are not serious issues, okay? But again, when you have questions, ask them, because there's a very easy answer in most cases, okay? All right, now, last on this list is big word, dermatochalasis, okay? It's a drooping eyelids, okay? To put it specific, dermatochalasis is when the skin underneath your brow starts to loosen and thin out and actually weigh down your upper lid, and it pushes your lids down. This happens to everybody. I don't care who you are. It's going to happen, and it does happen. And the other one is, we wrote down there, is ptosis. Okay, ptosis is a lagging of the upper lids that has to do with the muscles that control the raising of the eyelids. They loosen up a little bit, okay? And like I said, just literally why they loosen up is because the way muscles attach to ligaments, and those connection points start to fray and they loosen up. So it slackens. This is something that some people are very acutely aware of and other people are totally clueless that it's happening. And you know what, if you're clueless, that's fine, because if it's not bothering you, we won't talk you into it bothering you. We won't. But it does cause problems. It does limit your visual field in some cases. So I wrote decrease in visual field or light transmission into the eye. It's like kind of having, like being a little bit hooded. And let me tell you, that's relevant in the aging population, because guess what else happens? Well, literally all the other things we just talked about. Cataracts, you're using glasses. Now you have a constricted visual field. You have filtered light coming through. So it could be all of these things. So, sometimes we lean more heavily towards one thing being the main culprit to someone's problem, but there could be other secondary things going on. Sometimes this is a secondary issue. Other times it's a big time problem. And it's not just, look, some people, it can be purely cosmetic. From a functional vision standpoint, it's like when I do this, I raise my lids, I see better. Yeah, it's not an overly technical phenomenon why that's the case. It just limits light coming into the eye. It also, and I wrote refractive variations. Well, what that means is it can change your ability to have a prescription check in an eye exam room and have it accurately done. So it's like squinting during your eye exam. If you have something that's blocking light coming into the eye, well, it's also blocking part of the shape of the eye that defines someone's prescription. So that can cause some inconsistencies there. So I've had a number of exams where someone's eye, the way it looks, cataract level or lack of cataract, or their retinal health level, which is their macula or lack of a macular problem, looks like they should see a lot better, but their lids are coming down, and it's making their prescription check not be able to put light in the right spot of the back of the eye. And so that happens to varying degrees. And again, that's just that issue. You have all these other things. Dryness can mess around with your vision. All those other conditions. So there's again, what we're doing is we're kind of building a case for why there's a number of things that can cause normal vision problems that all happen to varying degrees. You're all going to experience it one way or the other, okay? Of all of those, I would say that the lid issue, while it does exist in everybody, it's probably the least recognized from a patient perspective as a problem from both from their own experience and probably even what they're going to hear from their doctors. Okay. Now, I wrote common but abnormal. That's kind of going back to the original first page of, we have normal changes, and then we have common but abnormal, okay? Which means it's a common problem, but not common to every individual person. All right, so this is what you can sometimes expect. Metabolic and vascular disease, okay. High blood pressure, high blood sugar, so diabetes, hypertension. These can cause massive issues with the eyes. Diabetes, fluctuating refractive error, your body swells with sorbitol and cortisol. When your blood sugar is high, that tends to pull in water to the structures that have it the most. Okay, your eye is one of them. Before you have cataract surgery, that lens will swell with water when your blood sugar is up, and that can also change the power of the eye. Now, when your blood sugar improves, it will improve, or the change will reverse itself. And that's a good thing that it does that, but it can make getting glasses for people sometimes a little more complicated, because they may come in, they may be seeing poorly, and a prescription change helps them. But if we see, let's say their A1C is very high, that's basically a number that reflects their overall blood sugar control. We'd be like, I wouldn't get these because there's a decent chance they'll be the wrong numbers when you improve. There is no magic blood sugar level that we can tell you that if you cross this threshold, now your prescription is going to be a phony prescription. That doesn't exist. It's a range. Therefore, it becomes a talking point during an eye exam. Okay. The other way is that high blood sugar can cause problems is it can damage your retina, just like it damages other parts of the body. So blood vessels, nervous system, tissue. And so that would be retinal disease, can cause stroke in the eye, not just in the body. High blood pressure, again, can cause systemic stroke. It can also cause strokes in the eye. The optic nerve can cause your blood vessels sometimes cross and constrict and get occluded. So you could have vision problems that are due to those issues. That's why when they ask you your medication list, how's your general medication, general medical health doing? It's very relevant to the eyes, but also what we see in the eyes can be very relevant to your general medical health and what your primary care doctor or your endocrinologist or whoever is seeing you, cardiologist, they'll want to know how your eyes are doing, because it's supplemental information for them to gauge your control. Okay. What we wrote here, another hypertension, hypotension, vascular occlusion episodes, TIA, stroke. Okay. Your vision goes completely black in one eye, but not for a very long period of time. That's a phone call. You want to let somebody know. Okay. In one eye, if one field, it feels like somebody just turned off the lights in one eye. That relates to a potential blood pressure issue or an embolic stroke, which means you have cholesterol blockage somewhere in your carotid artery, and it's breaking loose a piece and it's traveling down the vasculature and lodges at a point where it disrupts blood flow from getting into the eye. And now your brain doesn't get information from the eye to give you any kind of vision. So it just goes away. It comes back. Okay. But if that type of thing happens, obviously we'd want to know about it. That's on the more acute side. And there are other conditions. Okay. But these are big ones because, and again, in the aging population, one of the most common occurrences I'll have is that we'll have people who are having these symptoms, and a lot of what they're describing may be, and from our perspective, totally benign, but they share an awful lot in common with symptoms of major issues with the eyes, with big floaters, or with, they may have a little bit of a weakening in their field. It could just be to what we call orthostatic changes, where blood pressure changes when they're sitting up or sitting down. May not necessarily cause a stroke, but may give them a phenomenon like that, or somebody may get lightheaded. Again, more common when you're older because of our weaker circulation. You may have phenomena that are similar to this. Well, we want to hear about this. And the first thing we're going to do is try to rule out that it's not the worst thing, and then make sure that we're not ignoring everything underneath that. Okay. The ambiguity level, or I'm not quite sure what they're describing level, increases over time. Okay. We don't become less worried about these things over time. We generally become more concerned. Okay. And so those are the types of things that will, in our conversation, we're always going to be keeping in the back of our mind, are we dealing with one of the really serious cases? Or are we dealing with something that we need to say, hey, this is what could be serious about it. This is what I think it might be. There's generally going to be coordination between your primary care doctors and what we do when we deal with situations like that, okay? All right, next page. Let's see. We have macular degeneration, okay? I will go ahead and just right off the bat say it can affect anybody. It is much more heavily biased into the Caucasian population than it is the African American population. It just is, okay? But about 4 out of every 10 patients, and I guess you could say in that demographic, 85 years of age or older will have some degree of this, okay? It is highly associated with aging because of the increased levels of inflammation, oxidation, and weaker blood circulation. To this day, the single biggest modifiable risk factor for AMD or age-related macular degeneration is smoking, okay? The reason being is that it does everything that aging does to you, except at a much early age, okay? And so that's where the connection goes, okay? There's a hereditary component, which means that if it runs in the family, that a lot of people, that's a concern. There can also be an individual genetic predisposition, which means you may have a relative who's in their late 80s who has it. Nobody else does. It's probably more exclusive to that person, but becomes a more prominent issue in the aging population. And when you have more catastrophic vision loss due to that, our conversations become much more tailored to dealing with specific management strategies for maximizing usable vision, okay? Which means specific to reading or specific to watching television. And that may be even more specialized versions of the single vision glasses we talked about. Instead of bifocals, again, that all kind of harkens back to that discussion. In some cases, low vision. Low vision is when there's very weak vision, and we'll generally do a referral where we have a subspecialty come out to you, assess your vision level so that they can outfit you with specific instruments, which are the non-conventional instruments to maximize, help get better magnification, or in some cases, telescoping vision, which means small targets far away. These are not standard devices, but they specifically work with those, and they specifically work with you in the place where you live, and it can be assessing lighting, even where lights are in relationship to where you sit. That's becoming as a much more common issue with patients in their 80s and their 90s. And there are plenty of patients that I have seen, and we will end up suggesting a low vision evaluation. Okay, so that's a big one there. Oh, in regards, one last point about macular degeneration, you will hear wet, you will hear dry, those terms. All macular degeneration is dry, okay? Wet refers to when the body starts to produce these bad neovascular blood vessels in the back of the eye. It's trying to get more oxygen to the retina to stop the problem, but it doesn't help. And these blood vessels are leaky, and they will inevitably leak, and that can cause further damage. That's what we call the wet stage. That will be treatable, at least to the point of hopefully stopping the progress, and then maybe reverting back to just whatever the dry stage was. That's going to be done via referral to a retina specialist doctor, okay? At this point, there is no good treatments for macular degeneration that's in the dry stage. The eye vitamins that you may see on the counter, this is a big one, they don't stop macular degeneration. It doesn't run counter to the course of that disease. What it does is it helps to make sure that you don't have lower than level macular pigment levels, okay? Macular pigment levels, you want to have a good level. If you have macular degeneration and your levels are weak, it's worse for the condition, all right? So that's why we suggest people take those, but it is not preventative. If you don't have macular degeneration, you taking these vitamins is not going to stop you from getting it, okay? It does not offer preventative value there. Now, there are sillier things that you can do. Then take something like that. Eating lots of green leafy vegetables and the right kind of fruits will give you the same stuff that you're getting from that. That just ensures that you're getting it. And especially for those who are on, let's say, blood thinners that can't take multivitamins that contain vitamin K or other blood thinning supplements, then that's a direct, supplementation of the lutein and zeaxanthin. That's the antioxidants in the eye vitamins, or what you might see as ACAPs or ACAPs too. Okay, so that's a common question: is what are those eye vitamins about, or can I take vitamins to help my vision, or if I eat enough carrots will help? They're not disease preventative, but there are certain things that are just good to do in general. So keeping medically healthy is just about the best thing you can do and not smoke when it comes to that. Binocular vision. I know I'm blurring through these, but I want to get to your questions if there aren't any. Binocular vision. So that's the ability to have both eyes work together. In the last 5 years of my experience, it's not necessarily that I'm seeing more of this. I'm just seeing more of it in the aging population, more so than maybe the middle-aged or even, our early age, patients. And it's under the radar because it's extremely difficult to catch this as a problem unless somebody comes right into the office and says, I'm seeing 2 of everything. Okay, that's double vision. And I'm going to be excluding the acute onset double vision, which can be induced by a vascular event or a neurological problem or neuromuscular problem, or a thyroid issue. Those are all things that we would test for if someone comes in, acute onset double vision. But where it becomes, and that is, again, more common in the aging population, just like a host of conditions are. But when it's a muscular weakening, it can be one of the most difficult things to manage. And it can be one of the most difficult things also for a patient to be able to volunteer information that is very to the point on. Because if they're not seeing 2 of everything, then it may be like, I just can't get these glasses to work. And their vision may be great in both eyes. But the point being is that they're not great together. So in most cases, it's a weakening of the ability for our muscles to control where our eyes come together or turn out. So it's to either turn in or to turn out. And in most of these cases, people have a bias in their muscular posture from a very young age that they just progressively have a harder time overcoming by the time they get into their into their latter stages. Okay, those are going to be generally managed with Prism. These are specific additions or specific types of lenses that are designed to help the eyes move together to where they're comfortable to maintain single vision. So if you have a problem moving your eyes out to see single vision, then we help you do that with the Prism. Have a hard time pulling them in to see together up close or whatever, the Prism will help move the images to a point where the eyes can actually manage to come together and see single vision. But it is something that, again, a lot of this is also on the eye doctors, is to be able to listen to what the patient's saying and to be able to see this as a problem that they're not specifically vocalizing. They're not necessarily saying, I'm seeing double. So if you start hearing questions, and this can get repetitive from a patient perspective, so I'm just gonna let y'all know, if they start asking you, do you ever have to cover one eye to see clear? Okay, that's relating to double vision, or we call binocular vision weakness. Or if you feel like when you start reading for short periods of time, things are starting to run together. That can be an indication of binocular weakness. And again, there may be nothing wrong with the glasses, but there's something going on with the way the eyes are working together. That becomes more of a problem over time for people. And again, one of the single most difficult things to ascertain in a patient history. That's where the technician or doctor is asking, all right, so tell me what's going on. You know, not everybody's just coming right out with double vision, but it is a big issue. Okay. And lastly, we have Blepharitis. That's eyelid disease. And over time, this becomes more of a problem, just like all these things. It doesn't happen to everybody, okay? But it is not uncommon. All right, that's basically caused by inappropriate levels of metabolic activity by your own bacteria, normal bacteria that's on your skin, in your tear film. It's supposed to be there just like it's in our gut and everywhere else. They can sometimes become too excitable and overproduce these little byproducts that irritate the eye. They get into the oil glands in our lid margin and they break down the lipids into these irritating soapy-like components, causes inflammation. So your eyelids become stopped up, the oil doesn't get out, dry eye can happen. Styes, those are the big painful knots that you'll get when there's either an infection or just a big burst of inflammation in there. The other thing is kind of like your non-infectious conjunctivitis. I see this a lot, especially in assisted living facilities. It is not necessarily due to poor hygiene, it's poor hygiene stimulation, which means it gets harder for us to control our hygiene levels, even with proper attention, due to, again, increased levels of inflammation. You also have drooping skin, which means now there's more surface area and there's more cracks and crevices in the skin for the bacteria to get, it just to stimulate its own issues there. And so I see more conjunctivitis, I see more dryness, allergy spectrum issues related to blepharitis or things on the spectrum of this. Well, it just looks like the eye kind of look red, watery. I can't tell you how many times I encounter patients in assisted living facilities, or not even in that, just in the aging population that are dealing with this. So this basically behaves like a cyclical allergy, and can sort of disguise itself as like, I don't know, like it could be a vision problem for somebody. They're just like, I'm having to blink 30 times to clear my vision up, and then it goes blurry, and then this and that. And look at their eyes, they may be watering. Their lashes may look like they're kind of glued together with mucus. It's really a common problem. And so it can induce episodes of conjunctivitis, chronic dry eye disease, and again, does parallel deteriorating lid and skin hygiene. Okay. Now, that's not everything, but those are the main things that I have seen that probably cause the most, I would say, recycled issues that I see in the aging population. It's really all of those things. And so I find myself being able to kind of categorize these different, patient encounters, and it gets more and more specific. It's like, yeah, there's like 3 or 4 things that I just know that I'm going to see in a patient or multiple patients today. And a lot of it does fall on the doctor to really help provide information to the patient. It does take longer time. It takes more time spent in the chair with patients. Now, I do that because I don't think that there's a better way to kind of practice. But another thing, and this does play into the aging population, when you get into these practices that are high volume, you may be waiting a while, especially when you have a lot of patients in the elderly population, because these conversations by doctors that are doing a good job, these conversations are happening. It's not something that's going to be glossed over in 2 minutes. So when we're doing that, it's to make it so that they're not just dismissing what I'm saying as like, oh yeah, it's this, that. In the last 10 eye exams I've had, it's been the same thing. At some point in time, it needs to be addressed so that a lot of that falls on the doctor, but also as a caretaker for either elderly friends, parents, aunts, uncles. They're going through these things, and they're having eye exams in some cases that are dealing with this. And sometimes they're having interactions which may not be everything they need to hear, or they may have heard it, but it may not have sunken in. That's okay. It might have to come up again, but they oftentimes relate to these topics here. So anyways, that's those topics there. Does anybody have any specific questions? And you can go back to any of these things, or if it's something I didn't even mention, I'd be happy to answer any questions.
I have a couple of.
Okay.
One of my questions is, going back to the line bifocals and
Yes.
bifocal, which do you prefer? Which is better than the other?
Okay, that's a good question. I actually don't just blindly prefer one versus the other. I would look at it as a very situation-specific thing. So line bifocals can be easier to use in some cases because they are more straightforward. The power above the line is for distance. The power below the line is going to be set for book distance, not computer screens, but for things within that 16 to 22 inch range. That is better for somebody probably who is more prone to motion sickness issues versus a progressive lens. Progressive lens is the no line that has multiple near powers that allow you to see out here all the way down to here. But it costs a lot more, which, by the way, that's okay, but sometimes it's not. But it could also be, there's more things in the way those lenses are fabricated that can cause secondary issues for people who tend to be motion sickness prone, or it could be somebody who has limited range of motion or comfort in their head and their neck, or they may have a neurological condition like Parkinson's where there's a generalized stiffness. So it's all about usability. One inherently is not, and I know this is just the truth, one inherently is not better than the other. Something can be perfect for somebody and be terrible for somebody else. That's really how it is with those. So I really prefer one versus the other for patient-specific reasons. Okay.
Another
Go
question
ahead.
is, what causes blue eyes?
Okay, so in the aging population, it's not that the eyes are turning blue. In many cases, the cornea, that's the clear domey window on top of the, right in front of your iris, which in probably most of our cases is going to be brown. It just has more iris pigment. Less iris pigment than brown looks hazel, less iris pigment than hazel looks blue.
Mine
Less
turned blue.
Right, but what it is that on the peripheral areas of the cornea starts to become a little bit more opaque. And the technical term is arcus. And arcus is just where it starts to opacify at the perimeter edge of the cornea. It is not vision affecting. But when you're looking through that opacified area, that's kind of like a slightly whitish opacity, and you have a dark pupil behind it, it refracts as blue. It looks bluish. The eye actually isn't blue.
When someone looked at my eye.
Oh, they'll tell you. Well, it's just like,
They could tell
if you look, and
I
if
have
you,
blue eyes.
exactly. The truth is, if you were to look under a microscope, there's nothing blue about it. It's just like looking at a painting up really close. Or certain birds with feather colorations up really close. The further away you get, it looks different. So light plays off of those surfaces different, but it's the fact that light is going through not just a clear surface, but it's going through an opaque whitish surface, and then it's hitting a brown surface behind it. And you're not seeing the surface behind it, you're seeing light coming back at you through those multiple surfaces, and it does give it a bluish look to it. I know exactly what you're talking about, yeah. There's nothing you do about it. It's not a,
I didn't even know it.
yeah, oh yeah.
People, I was told, well, you got blue eyes.
Yeah, yeah. Chances are, if I were to look at you close, you have that little white ring there. It's very common in the aging population. If I see that in much younger individuals, there could be some cholesterol concerns, but that's generally not what it is when folks are just going through their years and you start to see that. But yes, you're going to notice that more with patients, that phenomenon, when you have darker iris. Okay.
You didn't mention.
Oh, I'm glad that you brought that up because that's a big one. Yeah, thank you. I skipped over that. All right. So something sounded like it was there. Okay, so glaucoma is also not a normal condition. Okay, it is more common over time. It is also more prevalent in the African American community. And by the way, if we leave this continent, all these numbers and variations change. So there's genetic components to this stuff, but basically how it's relevant to everybody here is that, glaucoma is one of the big words. It's one of the big, glaucoma, macular degeneration, cataracts. And it's an optic neuropathy. So the optic nerve, which basically forms the retina, directly connects to your brain, can degenerate due to either high eye pressure, weak blood circulation to the back of the nerve, or again, without getting nitty gritty on it, sometimes there are high pressures can trigger the activation of cells that have gone dormant in the eye that can attack the optic nerve head. And their purpose was more during the embryologic stage to cull the number of nerve cells so we can actually power the eye once we are born. But that's still what we do is all about lowering pressure. So that's to this day, the only modifiable risk factor is to lower eye pressure. Okay. It's extremely treatable. In the vast majority of cases, it's something that is highly preventable. Routine eye exams in most cases can easily root out a glaucoma suspect. And there are, again, as I wrote down there are more glaucoma suspects every year than there ever has been, just because of the way we can test and manage this condition. We check peripheral vision. We check the optic nerve itself with laser scanners or with ultrasounds. And we just look at it. And we look at eye pressure. So highly treatable drops. Sometimes when drops are not enough, certain surgeries are done, and certain medical surgeries that are non-laser are done. Fortunately, that is not that common. It happens, okay, but it's not that common, but they're all to modify eye pressure, okay? It is. But it is uncommon for it to cause significant damage. It does happen, okay? But this is a highly manageable, in most cases, highly preventable major condition that a lot of people do deal with, okay? But it damages your peripheral vision first if it is allowed to, or if it just continues to be a problem. And then it gradually kind of tunnels into eventually attacking your central vision. That's very rare that we get to that point, though, okay? Again, as I wrote, glaucoma suspicion is more common now due to how treatable and how multi-tested it is. There's a lot of ways to figure out how somebody can be a suspect for that. It's a big word, so if you hear glaucoma suspect, you don't want to freak out, okay? But you want to be concerned enough to listen, to what they're saying. It can be a hereditary issue, no question about that, but sometimes it's specific to one person's genetic predisposition. Okay, thank you for mentioning that, because that was one of the main points there.
Question,
Yeah, go ahead.
what's the normal number range?
Okay, so 10 to 20 is the average eye pressure range. Okay, now glaucoma can exist even when your eye pressures are quote unquote normal. All right, but if you don't have that type of glaucoma, then in general, where we start to become concerned if their optic nerve looks normal or whatever variation of normal they look like, when the pressures start to go from mid to upper 20s. That's generally where all things being good, pressures mid upper 20s is you're suspicious now. We call it ocular hypertension. Now you can have glaucoma and your pressures be barely above the average range, and that's where it's a little bit more complicated, but we're still all modifying the pressure with at first with drops. So you may just be like, hey, your optic nerve looks good, your pressures are 20, that's fine. Let's say 5 years down the road, you start to see 21, 23, 27. Now there's going to be some conversations that are to be had. But what I would tell you is if you're getting a number 15 versus 10 or 19 versus 15, the person who has 15 is not better than a person who has pressure of 19. It's not that simple. But to answer your question, the normal, quote unquote, normal range or most commonly encountered pressure levels are between 10 and 20.
Okay.
Yes.
Till you, what was I gonna say? Be tested for glaucoma or either routinely test for glaucoma, what age bracket?
Okay, that's a very good question. It is somewhat controversial, but not necessarily in a negative way. A lot of practices, not pediatric ophthalmological practices, a lot of practices start checking eye pressures on like 13 years old and up.
Okay.
There's nothing wrong with checking it on somebody who's younger than that. There may be a reason, okay? But any routine eye exam with kids of that age and up is going to include an eye pressure check.
In a routine.
In a comprehensive eye exam,
Yeah,
exactly.
yeah.
Now, there could be lots of other exams where we check eye pressures because it's associated with other issues, or it could be a secondary issue too, but we just want to know what their eye pressure is doing. Then sometimes it will be done on non-comprehensive eye checks, but on a routine basis, it is part of a routine eye exam, is to do an eye pressure check. It's a great question.
One more question.
Yeah, go ahead.
When is it best to use blue light?
I'm glad you mentioned that. Okay. So here's the deal on that. Parts of the color spectrum, specifically the blue light, has a certain area of wavelengths which don't travel through the human lens and basically stay in its lane. It crosses over into other wavelength paths of other color spectrums. That can cause a little bit of discomfort in your vision, a little bit of it's a type of a blurriness that's very hard to describe. So it could be, an eye strain issue for some people, okay? My personal suggestion is if you can make the adjustment on the monitor that's producing that spectrum, that's your best bet. Because now you're not introducing another lens or another layer in front of your eyes that can cause its own secondary glare. So for example, and again, this is not always relevant to every age range, but let's say you wouldn't normally wear glasses to see something at the computer screen. And they put on a pair of glasses with blue light filter versus just making the adjustment on the monitor. The adjustment on the monitor is always going to be better because now the person who has the glasses in front of them, they're not anti-reflection coated. You're going to have a little bit of spectacle-induced glare there. So it's not a bad thing. It's just my personal preference is if you can make the adjustment on the phone or the tablet or the computer monitor, that's generally preferable. And that I do think it's something that is it's an increasing problem because we are more integrated to technology now than we ever have been before. There are some studies, and I can't quote you them because I don't know them. So a lot of this is kind of, I say hearsay, but it's pretty common knowledge at this point that it can inhibit melatonin release, which means that's why it's harder to fall asleep. So there's some effect on circadian rhythms for some folks. So when you're in front of those screens for a long period of time, you got that blue light coming in, there may be something to that. I don't think, and this is controversial, that it actually is causing damage to the back of people's eyes. There hasn't been research that has shown that to be, there's no consensus on that, okay? But at the same time, you don't need to be having that coming in that if you don't have to, because it's just gonna be a little easier on the eyes. The screen is gonna look warmer with the blue light filter, either in front of you or with that adjustment done to to the screen. It'll look like it just kind of warms up. And when it turns off, it looks like, oh, wow, everything is hypersaturated. It looks great. You could see either way. But yeah, I do think that I do bring that up to patients, and they they're usually more asking me about it than me just directly mentioning it. That's a very good question. Any other questions? Anything?
One more.
Yeah, go ahead.
This is a tricky one now.
That's okay. That's okay.
Okay, a lot of times I said, honey, where is such and such? And she said, he's lying right there. You know?
Yeah.
And I don't know if it's a coloration or whatever. Then when I be focused, there it is.
Mhm.
Now, like I said, for instance, when I'm outside, I can go to the mailbox.
Mhm.
And I put a mail out, and I start reading it, not realizing I don't have my glasses on.
Yeah. Yeah. So in everybody's case, and this is why group eye exams aren't done for obvious reasons, but not everybody with and without their glasses on is operating with the same hand, which means it's like if you are, for example, you have a certain amount of nearsightedness or sometimes nearsightedness and astigmatism, you can see up close without your glasses on.
Mm-hmm.
It's not always the same subjective experience as it will be with the glasses, in front of you.
Mm-hmm.
But that generally relates to whether or not you have some uncorrected prescription that gives you that vision. Now, by the same token, it's also the reason why when you look far away, it won't look good at all. So if your pre-focused clarity without glasses is more biased to up close, that's going to be nearsightedness, and that you can do that. And so, and here's the thing, before and after cataract surgery, those numbers can be different. So that's why the question can be asked multiple times over someone's lifespan, because they're in different situations before and after surgery. So it's a good question.
I have one quick question. Quick. If you had cataract surgery
Yeah.
and you had lens implanted that were for distance and for a
Near.
close,
Monovision, yes.
yeah, if your lens, during your eye visits thereafter changes, do you go back and have all that re-implanted?
No, because here's the truth of the matter is, in general, it doesn't change, which means that once that lens implant is in the eye, there's nothing organic about it. So it's not expanding in size or increasing in density. So now, it's not that there aren't some changes. In a lot of cases, there's going to be some very small changes. In some cases, it may be enough for somebody to even notice it. But in most instances, there's not going to be any real significant variation in the strength of the eye because of the implant changing. So if somebody has to have an implant taken out, there's generally going to be some sort of a complication that's not inherent to, let's say, how the surgery was done, but how the surgery was received by the eye in terms of the reaction to it. And sometimes, so when you have like situations going on like that, somebody may develop swelling in the back of the eye and stuff like that. Depending on how the topography is affected, it can shift the eye power. But at all costs, they want to avoid going back in, and unless they have to, in terms of disturbing that. But that's a great question, because for the most part, what we can safely tell people is that you should expect your vision to kind of stop changing, quote unquote, in terms of your glasses numbers once cataract surgery is done. Truth is, it can change a little bit, but for the most part, it's not significant. Okay, so they won't go back in there to redo a power issue. Okay, they usually try to vet the power issue that'll happen before the surgery's done. So that's part of the pre-testing. They calculate how long the eye is, how curvy the front of the eye is, so that they know what implant strength they need to put in to make it so that their uncorrected vision, which means their vision without glasses, is as good as it can be. It doesn't always work to where they want it to be. So you may have some power left over. That's okay. If you have the glasses on, then now you're still seeing as good as you can without the cataract in there. Okay, but they usually, at all costs, try to avoid going back in and doing another surgery.
Okay, thank you.
Sure.
I think we could talk and talk.
I know, yeah.
I
Sure.
think we need to let Jason, oh, you have one more question?
I just had
I'm
one.
sorry.
Yeah, go ahead.
Okay, the implant strength, is that based upon what your prescription would have been or will be?
It's what it will be.
Okay.
Now, but here's the thing. What it was before the surgery is a result of the length and the shape of your eye.
Okay.
So when they do those measurements, let's say if someone's 6 units nearsighted, they're saying, well, how much does how long the eye is play into that 6 units? Or how much does the curvature of the front of the eye, the cornea, play into those 6 units? Then, based on those numbers, they can simulate what implant strength needs to go in there to try to get that -6 down to a 0. Unless somebody says, leave me a little nearsighted so I can read without glasses. Well, that's can be done too. But that's kind of, I think is that kind of what you were getting at? Okay, yeah.
Thank you.
Jason,
Sure.
one more question.
Yeah.
How would that affect, diabetic neuropathy?
The neuropathy?
Yeah.
Well, I think it depends. So, all right, where it's relevant for cataract surgery? Are you talking about that?
After cataract.
After cataract surgery, okay. I wouldn't say there's any direct here's the potential direct connection between diabetic eye disease and cataract surgery. If you have active diabetic eye disease at a certain level, cataract surgery at that time is not recommended. It's contraindicated. Because if you have some bleeding or hemorrhaging in the back of the eye, the normal acceptable trauma that's involved in the cataract surgery can sometimes complicate the diabetic eye disease situation there. And sometimes the diabetic eye disease situation can complicate the post-operative inflammatory recovery and the types of drops you have to take for that. But I would say this, if you have problems with your vision and you have any type of peripheral neuropathy that makes moving around and getting around and going from point A to point B, anything that enhances your senses is good. So I would say you could take all the indirect connections, vision, hearing, all that kind of stuff. It's relevant. It's relevant. But specifically with diabetics, diabetic neuropathy. So if it's peripheral, that means just, your extremities and things like that. Reverse the eye, if you just have active diabetic eye disease in the back of the eye, that has to be vetted by the doctors. And in some cases, retina specialists to see if it's okay to actually do a cataract surgery. After that, that's why you want to do those surgeries when there's not a problem, if you can. After it, there's generally not a predictable problem back there. Just about every circumstance, in most situations, there's no problems. I still think to this day, statistically speaking, it's one of the most successful surgeries, if not the most successful surgery done in the body. So, but there are still some rules that you got to follow with that. So, I don't know if that directly answered your question, but
Thank you. I appreciate it.
okay, sure.
Thank you.
All right. Well, thank you very much.
You can clearly see how much we've learned and how much more we want to hear from Dr. Gould. Thank you so much for sharing all that information. Special thanks again to Carolina Pines for sponsoring our program today. And we invite you to come back, everyone, on October 17th at 11:30 for lunch and for the program at noon. We'll be talking about Medicare SHIP and other government benefits. Please RSVP online at ACAPcommunity.org. Thank you for being here today.
Thank you. Thank you so much. Interesting.